Okay, good morning, everyone, or afternoon, depending on where you are in the country. My name is Dr. Marlana Orloff. I'm a medical oncologist at Thomas Jefferson University in Philadelphia. And this morning, I will be given a presentation on adjuvant therapies in uveal melanoma. Unfortunately, once I start to share my screen for the presentation, I won't be able to see the live chat. However, if a question comes up as I'm talking, please put it into the chat. And then once the presentation ends around 11:20, I'll then go back to the chat and we can go through any questions that came up there. Okay. Okay. Hopefully everyone can see this. Again, the topic is adjuvant therapies for uveal melanoma. These are my disclosures. Okay. So first wanted to start by just giving a definition of what adjuvant therapy is. So adjuvant therapy is really additional cancer treatment given after the primary treatment to lower the risk that the cancer will come back. Adjuvant therapy may include chemotherapy, radiation, hormone therapy, targeted therapy, or biological therapy. When we talk about uveal melanoma, it's really any treatment that comes after the primary eye treatment. So whether that was enucleation, plaque radiation, external radiation, it's any treatment that's given after that to prevent the cancer from coming back. A lot of you may get injections in your eye, things like Avastin or steroid injections. That's not necessarily adjuvant therapy. That's more typically for preservation of eye vision and not necessarily specific to the cancer. So I'm talking about completely separate therapy. So how are adjuvant therapies chosen? So it actually often starts with drugs that are found to be effective in the metastatic setting and then moved up. So take, for instance, skin melanoma. You know, drugs like Yervoy, Opdivo, Keytruda, they were all first studied in patients with metastatic disease. And once they were found to look like they were effective there, they actually got moved up into the adjuvant setting. But not always. There are some adjuvant therapies for certain cancers that are different drugs that may be used in more advanced settings. Adjuvant therapy should really be studied in randomized trials to see if there's a true benefit. And these are sometimes harder to prove because unlike studying a therapy where you're trying to, say, shrink a tumor and looking for a response, trying to make cancer go away, you're really looking for a delay or prevention of recurrence. And because of that, trials can take a long time because, again, you're starting with a population that really has no evidence of disease, and you may need to follow them for years to see if the drug really did prevent or delay recurrence. Aside from choosing the right drug, choosing the right high-risk patient population can also be a challenge. So again, adjuvant therapies are in patients where the cancer was already treated. There's no evidence of disease. There are certain patients that the primary treatment was enough. That should take care of the cancer, and there may be very low to no risk it can come back. So you really need to define the high-risk patient population. So patient population where the tumor was treated, but there's still some concern that it may come back. So really trying to figure out who really needs it, because you don't want to treat everyone because there's still some, side effects that adjuvant therapies can have. So you really want to pick the right population. Current adjuvant options for uveal melanoma. There are no approved standard of care adjuvant treatments for uveal melanoma. The actual standard of care is surveillance. So surveillance meaning scans, exams, labs, and frequency and imaging modality is really depending on risk. So for instance, in my practice, once we assign, someone's risk of their primary eye melanoma, depending on things like size of the tumor, other features of the tumor, and then certainly things like cytogenetics or gene signature, things like Castle and whatnot. Depending on if the patient's low, intermediate, or high risk, we will then kind of tailor their surveillance schedule depending on that risk. And really, that is the standard of care. There's no approved specific treatments, which is why we are currently conducting, and others in the country, a number of adjuvant clinical trials in uveal melanoma. Again, understanding that there's a portion of patients who have a high risk of this thing coming back after their primary eye's treated, and trying to find an effective therapy to prevent it from coming back. So today I'm going to talk about 4 adjuvant clinical trials. This is by no means an exhaustive list of every adjuvant trial that's been done in uveal melanoma. But first I'll talk about Sutent and or valproic acid, which is actually a study that's ongoing that we've done here at Jefferson. Another study of ipilimumab and nivolumab, for which there's actually no data yet, but that one is ongoing and I'll discuss that one. Another study of adjuvant crizotinib. And another adjuvant study of, not interferon, DTIC and interferon. Okay. So adjuvant Sutent and valproic acid. So this is just a little bit of the trial overview. And I put up there what's called the NCT number, so you can actually look it up on clinicaltrials.gov. So again, this is adjuvant Sutent and valproic acid in high-risk patients with uveal melanoma. It is a site here at Jefferson. This is the inclusion criteria. And I really just put kind of the genetics information here, but also it's should be commented on that. So again, this is patients with primary eye melanoma that's been treated and actually has to be within 6 months. So you have to start the study within 6 months of the primary eye treatment. And the inclusion criteria for the definition of high risk is either monosomy 3 and 8q amplification, which are 2 chromosomal abnormalities that you find in the primary tumor, or what's called Castle class 2. The treatment details here, I have, we've done multiple cohorts now. So cohort 1 actually opened back in 2015, and this was Sutent versus valproic acid. It was randomized. And sorry, that shouldn't say 12 months. That was actually for 6 months. And then cohort 2 opened in 2018, and that was Sutent for 12 months. And then there was cohort 3, which just recently opened, and it's actually a combination of Sutent and valproic acid for 12 months, and that's enrolling. So what is the rationale for using a drug like Sutent, which is considered to block c-KIT in uveal melanoma? c-KIT is expressed in as many as 75% of metastatic uveal melanomas. And then we did do a study a number of years ago in about 20 patients with metastatic uveal melanoma where we gave them Sutent. There was 1 partial response, 13 stable disease, and 6 progressive disease. So it was thought that there was kind of a clinical benefit rate at least for a period of time of about 70% in this very small cohort of patients. So while it didn't necessarily, shrink tumors, there was a number of patients who had stable disease. So the thought was that perhaps if this drug isn't enough to really kind of eradicate tumors once we can see them, perhaps there's some utilization. We can use this drug maybe just when there's a few cells kind of floating around that had escaped the eye before we can actually see things on scans. So we had used this drug off-label for a number of years, and we did a retrospective analysis where we looked at patients who got Sutent compared to what we call matched historical controls, so matched patients based on age, tumor size, and genetics. And it looked like that the overall survival in the Sutent arm was significantly better than patients who got nothing. So it was 86% versus 55%. So here's just a survival curve showing that Sutent versus no treatment. Again, this was a retrospective study, and retrospective studies are, not necessarily the gold standard for proving that a therapy was effective, especially, again, because there was kind of matched controls here, and we weren't really controlling the Sutent group. They were kind of followed all the same way. However, it was with this kind of early signal that we decided to launch into a more prospective study. And so this is how the phase 2 study of adjuvant Sutent or valproic acid was then borne out. So again, similar inclusion criteria has to be within 6 months. And initially it was a 1-to-1 randomization of Sutent versus valproic acid for 6 months. And these were the endpoints. And we watched all patients equally, the same. So what is the rationale to use valproic acid? So I mentioned kind of the rationale for Sutent. So valproic acid, even though it's an old kind of anti-seizure medicine, also sometimes used for mood stabilization, it's also what's called a histone deacetylase inhibitor or an HDAC inhibitor. And it has been shown in a lot of preclinical studies to show that it could block uveal melanoma growth. So this was actually kind of a mouse study, and you can see here valproic acid versus control, and that valproic acid looked like it was effective in blocking uveal melanoma growth. So this was the schematic, again, for this initial study. I already kind of went through some of the details here. And the preliminary results of that very first cohort, there was 90 patients enrolled to the study, so kind of 45 in each group. So 9 of the 45 in the Sutent arm and 4 in the valproic acid arm could not complete the 6-month treatment due to some side effects, but overall it was otherwise fairly well tolerated. And the rest of the patients completed 6-month course of study with 2-year follow-up. And then cohort 2, which I mentioned was then just Sutent for a longer period of time, was created to investigate the safety and potential improvement of what we call the 18-month relapse-free survival. So trying to see and prolong the time that patients would potentially develop metastatic disease. So here's just some numbers here. So this is the 24-month overall survival of Sutent valproic acid versus the 18-month for Sutent valproic acid. And here just is comparing to that previous retrospective study that I had mentioned of the adjuvant versus no adjuvant treatment, or the historical controls. And it looks like the 2-year overall survival rate is about on point at around 94, 95%. And then you see that what they call the 18-month relapse-free survival. So at about 18 months, 75% of patients had not recurred in the Sutent arm versus the valproic acid arm, around 63%. So again, here's just another snapshot of cohort 1 and the 24-month relapse-free survival rate. So the hope is with a longer duration of the Sutent, perhaps we can push out that relapse-free survival. So like I said, cohort 2 is 12 months of Sutent only, and now cohort 3 is 12 months of actually a combination of Sutent and valproic acid. And data is still pending from these cohorts. And like I said, cohort 3 just started enrolling. So that is Sutent and valproic acid. Next, I will talk about a trial that is ongoing of adjuvant ipilimumab and nivolumab. So again, here is just the trial overview. There's multiple sites. You have to have Castle Class 2, or what's considered to be a 3-year recurrent risk of more than 50%, or monosomy 3 with thickness of 8 millimeters. And also the diameter must be at least 12 millimeters. So there's a little more specifics here for inclusion. And then patients will receive nivolumab IV every 2 weeks plus IPI every 6 weeks with a max dose of 25 doses of Nivo and 8 doses of IPI. So it's a little bit different than how we sometimes use IPI-Nivo in the metastatic setting. Again, this trial is still enrolling. We don't have any data yet, but I thought I would just throw up here. A study was done on adjuvant ipilimumab in high-risk uveal melanoma. This was a single institution. It was actually a dose escalation of 3 to 10. This was done at MD Anderson. There was 10 patients. Here's the inclusion criteria. And here we call disease metastatic free survival at 36 months was 80%, and they also compared to historical controls, which was about 50%. So this IPI alone in this very small cohort of patients did potentially show some benefit for disease-free survival, and we await the data on the adjuvant IPI-Nivo. Next, I want to talk about a study of adjuvant crizotinib. So crizotinib in high-risk uveal, again, the sites here were Columbia, Mount Sinai, and Ohio State. This is now completed. Need to have, again, the diameter of 12 millimeters and the gene expression profile to be class 2. And then the treatment details, it was 250 twice daily for 48 weeks. So here's the rationale for crizotinib. So this is a little bit animated here. Basically, and I know it's very tiny, the take home here is it looks like crizotinib versus control group here, limited growth of uveal melanoma in the mouse model and some preclinical models. And so here's just a quick snapshot of the results. So relapse-free survival rates at 12, 24, and 36 months. Showing, again, 81, 75, and 50%. And then here's some site of recurrence. So full data on this study is still not yet available. But like I said, the study is close to enrollment, and we should see additional data come out. Here, though, is they compared the clinical trial arm to the observation arm of the historical controls. And here it looks like specifically for overall survival, you can see the blue line versus the observation line, and there's a bit of a break point with relapse-free survival at 32.9 months median and overall survival of 48 months. So it does look like there may be some benefit to the drug, certainly in the overall survival. In the relapse-free survival, they do cross a bit there. So again, some additional analysis of this study is ongoing. And lastly, I want to talk about a study that was recently published. It was actually done a while ago, but recently published, of adjuvant low-dose DTIC and interferon. So this was dacarbazine and recombinant interferon in patients with primary uveal melanoma. The site was Cleveland Clinic. Inclusion criteria was monosomy 3 and or AQ amplification. And there you can see the treatment details. So this was the results of what they call the univariable analysis. So it was really just looking at the treated versus observed. It looks like the patients who did not receive treatment did have a worse, what we call metastasis-free survival and overall survival. However, in the study discussion and additional results, they did comment, though, that when patient age and tumor size was added to the treatment versus observation arm, so kind of as controls, it actually looked like the observed difference in metastasis-free survival and overall survival between the groups was no longer significant. So again, this is important, going back to the kind of one of the first slides that I mentioned, is when you're comparing the treatment arm to the group that didn't get treatment, you really need to make sure that they are matched so that the risks are the same. So again, that's age, that's tumor size, that's genetic information, because you really need to know that the kind of behavior of the tumors are the same in the groups to really know if there's a true treatment difference. So in conclusion, we are still looking to find an effective adjuvant treatment for uveal melanoma. Like I mentioned, 2 of the studies that I discussed are still enrolling, and I'm sure there's going to be additional adjuvant trials open in the future. There does, though, need to be agreement on what defines high risk. So some of the studies just use genetics, some use a combination of genetics and tumor size, some actually just allow large tumors. So I think in order to really conclude on what a true effective adjuvant therapy is, there needs to be agreement, and we really need to pick the true high-risk patient population. Though it's hard to enroll to a placebo-controlled trial. So again, the gold standard of an adjuvant trial would really be treatment arm versus an arm that does get any treatment. So it would just really be scans only. We can use these matched historical untreated control groups, but it's again hard because I think we probably lack a perfect match historical untreated control group. Different institutions have used kind of their own matched controls. But again, depending on how those control groups are followed, it may be different than how the treatment arms followed. So just need to be careful with that. And then the answer to finding the right adjuvant therapy may or may not be found in clues about effective treatments in the metastatic setting. So again, I think for a long time in uveal, we've been waiting kind of for that, super effective treatment in the metastatic setting before moving it up to the adjuvant setting. But we may be still a little bit until we find that drug that we can safely move into the adjuvant setting. So, there are trials that are looking at drugs in the adjuvant setting that may not be ones that we use in the metastatic setting. So we need to consider that as well. All right, and that is it. So again, I will now be minimizing my presentation and we can answer some questions in the chat, but I just want to say special thanks to Dr. Sato, Carvajal, Singh, and Patel, and Rapiswan for assistance with trial updates and slides. Thank you. Okay. All right. All right, hopefully, I'm just seeing now someone couldn't hear me. Hopefully they fixed that. Okay, and I'm just gonna go through the chat here. So there's a question from Lauren. If a patient had one trial but had to leave the trial, are they eligible for other trials? So I don't know if that pertains to adjuvant trials. So if we enrolled a patient on an adjuvant trial here and say they even completed the study for 12 months, we would not recommend, or they really shouldn't then go on another adjuvant trial. However, if they are on an adjuvant trial, say, and they get through and then they develop metastatic disease, then they could be eligible for trials that are different for that patient population. You do have to be careful sometimes because if it's a drug in the adjuvant setting, say like say that ipilimumab and nivolumab, there may be metastatic trials, especially first-line trials, where you can have had those drugs, or maybe you can't have had those drugs in the metastatic setting, so it's okay if you had them in the adjuvant setting. So these are definitely things that you should discuss with your doctor when you're deciding about an adjuvant trial. How can a patient qualify for treatments without genetic testing? So that's a good question. It's hard. Most of the trials right now do require genetic testing. And so, for instance, if I see a patient that I think may benefit from an adjuvant trial because their tumor, is a larger tumor, but they haven't had genetic testing, if there had been a sample obtained at the time of their eye diagnosis, we could always send that. Certainly, if it's an enucleated specimen, you can send that after the fact. The problem is you can't really send genetic testing on a tumor that's already been radiated. Sometimes the genetic information is not as accurate. So, again, the decision about getting a biopsy at the time of diagnosis for genetic testing is definitely something that people should be talking about with their ocular oncologist. And if it's not done at the primary treatment, again, enucleation specimens, we can probably check retroactively, but it's hard if it was like a plaque or radiation to go back. Where do you see the landscape of adjuvant trials going in the next 5 years for patients? So, I think our hope is, that there'd be an effective, treatment, like I said, in the metastatic setting to potentially consider in the adjuvant space. Again, that's how, other diseases have done it. But if we don't get there, or if the, effective treatment in the adjuvant space is something that doesn't necessarily in the metastatic setting that doesn't necessarily make sense in the adjuvant space, then I think as us researchers and clinicians and patients, may need to be creative and look at things like the preclinical models or, the mouse models that I showed to kind of inform us about what drugs we think might be effective in the adjuvant setting. So I don't think we need to wait for a, effective drug in the metastatic setting to come up with, adjuvant trials. And I think that's definitely what's been happening. I think we could probably, continue that and maybe even be a little bit, smarter about it. But certainly I think that's where it's heading. Again, the same is in the metastatic trials in uveal melanoma. We know it's obviously a rare cancer. So we always want to be careful in choosing not to have too many trials because then they can be hard to enroll to, especially because when you talk about high risk patient populations, that's not everyone that's diagnosed with eye melanoma. So again, it's kind of a smaller population within an already small population. Another question, are these treatments covered by insurance or are costs covered by the trial? So that really depends. A lot of times the drugs themselves, may be covered by the trial, but things like labs or the scans may be technically considered a standard of care. So because with or without the drug, you're probably going to be followed similar to as if you would if you weren't on study. So whether that's getting an MRI at a certain frequency or chest x-rays or CAT scans. So a lot of that I think is still considered standard of care, but often the drug is covered by the trial. Or if there's additional labs or studies that you wouldn't normally get as standard of care, that would also probably be covered by the trial. Another question, is the Sutent valproic acid cohort 3 only at Jefferson? Yes, as it stands right now, that study is only here at Jefferson. Okay, so it looks like we still have a few minutes. If there's any other questions, I think we kind of get shut down at 11:30, so we have about 5 more minutes. Is adjuvant therapy different in other countries? And if it's not available in one country, can a patient receive it in a different country? So I would say adjuvant therapy options are probably different in other countries. I know this is an international meeting this year, which is super exciting. And I certainly just gave a snapshot of some stuff going on in the US. I don't know if there's anyone in the audience that can speak on anything going on in other countries. It is very hard for patients to participate in trials outside of their country. That was difficult pre-COVID. It is harder enough, certainly I think even harder now in the middle of COVID. And that's because patients will typically need to be seen in person to sign things like consent, to potentially get the drug. And then again, issues of insurance. What does insurance cover? Insurance not covering. And then how the patients are followed. Again, with any trial, there may be frequent labs, and sometimes that's hard to manage. Outside of the country. At least that's been my experience. It doesn't mean, though, and again, it's hard now with COVID and travel, but that doesn't mean that if you're on a clinical trial in the US that you can't, travel outside the country. We always make arrangements if patients have travel plans and whatnot. But again, patients aren't traveling as much these days. So again, good question. Since COVID, are trials allowing patients to receive treatment outside of the medical institution running the trial? So I think that would depend on how the drug is administered. While I can't speak to say that the Ipi-Nivo trial, which is an infusion that you actually get on site, for us, patients come and sign consent for the Sutent valproic trial, valproic acid trial, but because they're pills, we can actually ship them. So we've actually been doing telehealths. So patients have to physically come here, sign consent. And then we've actually been doing telehealth and shipping drug to patients who maybe can't travel back here because of COVID. I'm not entirely sure how long that's going to last, because some of the telehealth laws have been flexed because of issues with COVID and travel. Again, with the Ipi-Nivo study, I'm not 100% sure. I imagine they probably still need to get the drug at the institution where they are consented for the trial, even though Ipi-Nivo is something that you can get kind of anywhere, because Ipi-Nivo, is an infusion, and because you have to really be monitored very closely for side effects. I don't know if it would be a good idea to kind of stray too far from the site in which you are consented and they're following you. Okay, I think we still have a few more minutes, like 2 minutes. Okay. All right. So if no one has any other questions in this last minute, I think we're going to wrap up. Thank you all for joining. I haven't even looked to see how many people joined. I think like 35 people signed up. Oh, just scrolling through the people, we have a lot of attendees. So hopefully you found this helpful, and hopefully you enjoy the rest of the meeting. Bye, everyone.